All right, good afternoon. Today I'm going to be talking about the role of pharmacy technology in patient safety. My name is Charlie Golding. I'm the second year pharmacy informatics resident at the University of Virginia Health System. So I will start with the vision statement of the National Coordinating Council for Medication Error Reporting and Prevention, and that is that no patient will be harmed by a medication error. And that will set the tone for the rest of our discussion. So first we'll talk about the types of medication errors. Different organizations define them differently or categorize them differently. And then we will talk about some patient safety organizations, some recommendations that are set forth by ISMP and some other organizations as well. And then we'll go on and we'll talk about specific systems, specific pieces of technology, and how they address medication errors. So we'll begin our discussion by talking about medication errors. A medication error is any error occurring in the medication use process. Typically, these are thought of as being preventable, and they can include any step from the ordering of a drug all the way to post-administration monitoring and following up of patients, including prescribing, dispensing from the pharmacy, administration by a practitioner, and monitoring. So the American Society of Health Systems Pharmacists, or ASHP, they split medication errors into many categories, including prescribing, omission, where a drug that should have been ordered was not ordered, the wrong timing of a drug, use of a drug that was not prescribed, things such as wrong drug or wrong dosage form, dispensing of a deteriorated or expired drug, and failure to monitor the patient. Integral in any discussion of patient safety and medication errors is orientation to what's called the Swiss cheese model. I believe by the diagram that I provided, it's pretty clear why it's called the Swiss cheese model. So essentially you have parallel slices of cheese. Each is a safeguard in the system. Each is a safeguard within the medication use process, representing prescribing, dispensing, administration. And as we further this topic and begin to talk about individual pieces of technology, you'll see that each piece is also intended to be a slice, as in each piece is supposed to be a safeguard that helps prevent and catch medication errors. However, each slice has holes. These are failures in the safeguard, whether this is a nurse administering the drug via a wrong route or the pharmacy dispensing the wrong strength of a drug due to errors in the system. The theme of this lecture is going to be making many slices and minimizing the holes as much as possible. So medication errors kind of became in vogue in 1999 when the Institute of Medication published a paper called "To Err is Human," where they concluded that preventing death and injury from medication errors requires dramatic system-wide changes to how processes are implemented. They recommend preventing, recognizing, and mitigating harm from error. And an important conclusion, especially for pharmacy, is that implementing actions to prevent errors in the first place has the greatest potential effect on mitigating medication errors. So medication errors can also be described in terms of the relationship between the error and patient harm. So the National Coordinating Council for Medication Error Reporting and Prevention classifies medication errors in this way. No error. However, there's the capacity to cause an error. Errors might not always happen, but maybe the situation surrounding a process is error-prone or could result in an error. There are medication errors that do not cause patient harm. Errors that do cause patient harm, this might require an increased length of hospital stay for a patient or increased needs of monitoring, as well as errors that result in patient death. So this seems grim, and there are errors that result in harm to the patient. However, these are the vast minority. Most errors do not cause patient harm. and these are called near misses. As a matter of fact, one study found fewer than 1% of medication errors resulted in an adverse drug event. However, we seek to get that number as close to 0 as possible, so there will always be an effort to minimize drug errors. Now, I've mentioned the National Coordinating Council for Medication Error Reporting and Prevention twice so far in this lecture already. This is a organization that was spearheaded by USP that leads the national healthcare organizations in meeting, collaborating, and cooperating to address medication errors, the causes of those errors, as well as promoting the safe use of medications. So back to the Institute of Medicine. Medication errors, they concluded in their To Err is Human, cause 1 out of 131 outpatient and 1 out of 854 inpatient deaths. And these rates are likely higher for drugs administered intravenously compared to drugs administered by other routes. There have been many studies that looked at medication errors, and these report up to somewhere between 4.8 and 5.3% of medications dispensed to have an error, with 0.9% of all errors resulting in adverse drug events. It's difficult to ascertain overall the incidence of medication errors because sometimes the only way that these are reported is through self-reporting, and different institutions, different organizations have different criteria by which they judge medication errors. And so the scope of this lecture really is medication errors leading to patient safety. However, there's also a financial cost of medication errors. The estimates and calculations of these vary widely, again, because they are calculated based on different criteria. National costs of medication errors is anywhere from $620 million to $26 billion annually, and per hospital is between $1.8 million and $5.6 million. So we're going to focus our conversation about medication errors a little bit, and we'll talk about dispensing errors, something that is a little bit more pharmacy-centric. So a dispensing error is a discrepancy between a medication order and the medication that's been dispensed pursuant to that order. Based on a bunch of studies, the reported rates of these errors is 0.06% all the way up to 18%. Most commonly, dispensing errors involve the wrong drug, wrong dosage form, wrong strength, and wrong quantity. Luckily, studies have generally concluded that dispensing errors that have been caught prior to the drug leaving the pharmacy are more common than those that are caught after leaving the pharmacy. There's also a meta-study, a study that looked at a bunch of other papers that described the factors contributing to dispensing errors. And this image might be a little bit small, but the kind of top contributory factors that were identified included an increased workload, similar drug names, similar packaging, and also inadequate levels of staff. As we get farther into this discussion, try to think about any factors that you might see in these images that can be helped to be prevented by any of the technologies that we talk about. We'll focus this even further for a moment, and we'll talk about high alert medications. So these are medications that have the highest propensity to cause harm when given in error. Examples of these being anticoagulants, insulins, opioids, chemotherapy, and concentrated electrolytes. So what causes these to be classified as high alert medications? Who classifies these as high alert medications? And why are these drugs inherently higher risk? For example, chemotherapy is considered high risk because of the complexity involved. It's complex for physicians to prescribe, for physicians to order, for the medication to be procured, the medication to be prepared, and then once it gets to the patient, these medications are often necrotizing and can cause tissue damage if not properly administered. and then we'll talk about high-risk processes. So similar to high-risk medications, these are processes that have a high opportunity for failure. If you think back to the Swiss cheese model of medication errors, these are slices that have larger holes. They benefit most from a proactive approach to error reduction, and some high-risk processes include preparing TPNs, sterile compounding, and chemotherapy preparation. All right. So before we start talking about some patient safety organizations and some technology, I've got a first learning assessment question for everyone. So which of the following is a dispensing error? A nurse administering a drug meant for another patient. B, physicians ordering the wrong medication for a patient. C, appropriate lab values not ordered for a patient. Or D, the pharmacy preparing a different dose than what the physician ordered. All right, and the answer to that is D, the pharmacy preparing a different dose of medication than the medication strength that was ordered by the physician would be a dispensing error. All right, so we'll briefly talk about some pharmacy organizations and patient safety organizations to kind of bridge the gap between a conceptual discussion of medication errors and the practical interventions that we use to prevent them. So first and foremost, I think the organization that pops in everyone's mind when you say patient safety is the ISMP, or Institute for Safe Medication Practices. So a little bit of background, this is a certified patient safety organization by the Agency for Healthcare Research and Quality. They're nonprofit, and their goal really is to prevent medication errors and encourage the safe use of medications. An important stipulation when we talk about ISMP is that they are non-regulatory. They publish recommendations. Some of the resources that ISMP produces and why ISMP is such a valuable organization includes a voluntary error reporting program. They collect self-reported errors from institutions around the country, and they aggregate this information and send this information out to organizations so that everyone can be aware. They send out ISMP medication safety alert newsletters. They also provide educational programs and guidelines, as well as a number of tools. These tools include the generation of a list of high alert medications, a list of tall man lettering for distinguishing look-alike, sound-alike medications, a list of dangerous abbreviations, as well as best practices for hospitals, which we'll talk more about momentarily. So ISMP, I bring this up in a lecture about technology and patient safety because recommendations that ISMP publish often involve the technology aspect of pharmacy. For example, ISMP publishes guidelines for safe preparation of compounded sterile products, and in this recommendation, they mention barcode scanning. They consider barcode scanning of base solutions and ingredients while preparing a compounded sterile preparation as a minimum requirement for pharmacy IV admixtures. When preparing chemotherapy, remember it's an even more high-risk process, they recommend barcoding as well as gravimetrics, which we'll talk about in a moment. So the ISMP I mentioned publishes what they call best practices for hospitals, I believe on an every year or every 2-year basis. And the 2018 to 2019 medication safety best practices for hospitals included some rules around dispensing oral liquids and making sure that oral syringes are not compatible with any tubing, and that is to prevent their intravenous administration on accident. They also recommend not stocking bulk oral solutions of medications on patient care units. Now that doesn't sound like it's technologically oriented, but I'm trying to make the case that pharmacy technicians have the ability to help participate in patient safety. Also included in the 2018-2019 best practices for hospitals is some language that is focused around technology. And so they encourage the use of technology to assist in the verification process. They encourage and recommend barcode scanning verification of ingredients, as we discussed, gravimetric verification, the incorporation of robotics into their workflows, as well as the use of IV workflow software to help standardize workflow. However, they also caution that any technology that is used must be maintained, calibrated, updated, and used in a manner that maximizes the safety features that are inherent to the technology system. We'll talk briefly about USP, or the United States Pharmacopoeia. They create and publish quality standards for drugs. I think when someone thinks about USP, they probably think USP 797, which is guidelines, procedures, and compliance requirements for compounding sterile preparations. It also includes language about the calibration of automated compounding devices, which we will talk about later. And lastly, in our discussion of pharmacy organizations, we'll talk about ASHP, or the American Society of Health Systems Pharmacists. They provide a lot of resources oriented around patient safety, including drug shortage updates, drug recalls, guidelines, such as guidelines on the safe use of automated medication storage and distribution devices, as well as they publish statements, which is kind of their stance on various topics. For example, they published a statement on barcode-enabled medication administration technology, which they are for. All right, so before we start to drill down and talk about individual pieces of technology, I've got a second learning assessment question for everyone. So which of the following is true? A, the ISMP recommends against the use of technology in the IV room. B, ISMP regulates the use of technology used when compounding sterile products in the pharmacy. C, ISMP recommends making sure that technology is used in a way that maximizes safety. Or D, ISMP recommends that oral liquids are administered directly from bulk bottles to patients by nursing staff. All right, so the answer to that one is C. The ISMP recommends making sure that technology is used in a way that maximizes safety. And remember, the ISMP doesn't publish regulations, they publish recommendations. All right, so we'll get into the meat of this lecture, some pharmacy technology. So a brief overview. Pharmacy technology is used to help increase efficiency and accuracy of dispensed medication. If you work in a hospital pharmacy, you undoubtedly use a whole lot of technology, a wide variety of technology that serves various purposes. It's important to recognize that technology is not inherently great or helpful or useful, but when used strategically and correctly, that's when you can benefit from increased efficiency, efficacy, and safety. It's also may not come as a surprise, but it's helpful to keep in mind that technology that supports the medication use process is inherently complex. Some of the things that must be established in order to support this technology include building databases, redesigning workflows, purchasing new hardware, and training employees to use the technology. A little bit further on that, the implementation of any technology requires understanding of the features of the technology as well as the limitations, evaluation of your current workflow, and modification of future workflow going forward in order to incorporate the new technology and minimize the failure points once that technology has been incorporated. And that is, again, to minimize and shrink the holes in our Swiss cheese. Something that I feel is a common theme is the sentiment, why didn't the technology stop the error from occurring? The technology exists. If an error still happened, why didn't the technology prevent that? And it's important to remember that technology is only as good or as useful or as efficacious as the people implementing it and the people using it. So the first individual piece of technology we'll talk about is IV workflow systems. So these are systems that augment IV room workflow via automation. They help standardize processes in the production of sterile compounded preparations, including the preparation process, verification, tracking, and documenting. It's possible that these systems feature a work queue for the prioritization of doses, product verification using any of the following: barcode scanning, gravimetrics, or image capture, automated calculations so that pharmacy staff doesn't have to continually convert drugs from milligrams to milliliters when they're drawing up solutions, etc. Electronic pharmacist verification is a feature of a few systems where pharmacists can remotely view compounded sterile preparations with via picture of the preparation and verify it remotely based on that. These systems may print a barcode for use later in the administration part of the medication use process. And these systems can also keep track of and assign beyond use dates. Something important to define, because I've spoken about it a few times here, is gravimetrics. So gravimetrics is the use of the specific gravity of a solution to determine the amount of drug that has been added to a final preparation. And this helps to ensure the accuracy of doses that are being prepared in the IV room. Essentially, gravimetrics is just weighing the product to make sure that the correct amount of additive has been added to the final solution, because each solution has a different weight or a different specific gravity. So IV workflow systems have been studied before and after implementation to see whether or not they have a real impact in patient safety. One study showed an improved accuracy of their IV sterile compounded products, as well as improved patient safety. They reported an increased detection of preparation errors, as well actually a 74-fold increase in the detection of these medication errors. Another study was published about the implementation of a barcode IV workflow system, and in this study, 22% of medication errors that were identified after implementation of this IV workflow system would not have been able to be identified prior to the implementation of this barcode system. So again, a reminder that the technology is only as good as it is being used and being implemented. An IV workflow system is not inherently good, but if it's used strategically, it can help to increase patient safety as well as the accuracy of doses that are being prepared by the pharmacy. Dispense prep and dispense check, as we call it, is a feature of Epic, a pretty popular EMR that is an IV workflow system. The top of this picture, you might see that it's got information for an individual order that's being compounded in the IV room. Below, it has both ingredients involved in this mixture, not only a vancomycin injection, but also a dextrose solution. On the right side of the image, it's got the dose, and whether or not this was scanned will show up when the product is barcode scanned. So next we'll talk about automated compounders. These are robotics that are used to aseptically transfer sterile solutions into a final container. And its aim is to increase the accuracy and reduce preparation time associated with sterile compounds. These are often used for TPNs. They usually feature a lot of ports, which is perfect for solutions that require a lot of different additives. Features of automated compounders include gravimetric or volumetric assessment of dose accuracy. These may interface with the medical record or the physician order entry system. These usually feature dose warnings. And as a matter of fact, ISMP recommends that if you're using automated compounding devices, to incorporate soft and hard dose limits in order to maximize the accuracy and the safety of the final product. We'll also talk about automated dispensing cabinets. So automated dispensing cabinets are decentralized medication distribution systems. They automate the storage, dispensing, and tracking of medications. They're decentralized, meaning they're typically kept on patient care units where the medication can be close to the patient and the staff that would be administering the medications. Most of the automated dispensing cabinets now feature single access drawers or single access cubbies called cubies for Pyxis. And this allows tighter access and control of drugs because when a drug is dispensed, staff retrieving the medication from the ADC can only access that medication. The impact that the incorporation of automated dispensing cabinets have in hospitals is controversial, as really is any technology system, because it's so dependent on so many factors of its use and implementation. But the inventory present in the cabinet, how often and how it's restocked, as well as the location of the cabinet, are all factors that are really important into whether or not it's been successfully implemented. Another aspect of automated dispensing cabinets that's important is the distinction between profiled cabinets and non-profiled cabinets. So a profiled cabinet is one where medications can be dispensed only after pharmacist verification. And this is great. This meets a lot of safety standards. For example, Joint Commission's medication management standard for pharmacist review of all new orders, as well as the ISMP, what they call core process number 3, from their guideline on the safe use of ADCs. They recommend using profiled cabinets. There's also non-profiled cabinets where drugs can be pulled before a pharmacist does the final verification. So there are quite a few studies out there looking at the before and after implementation of automated dispensing cabinets. One study found a decreased incidence of dispensing incidents, as well as an overall decrease in the error rate. A lot of these errors are drugs being given at the wrong time, or the wrong strength of drug being dispensed. Additionally, there was a study of an automated dispensing cabinet implementation in an ICU where total error rates decreased from 20.4% to 13.5%. Wrong dose errors here declined from 3.8% to 0.5%. Another noteworthy study was implementation of ADCs in a surgical ICU and in a cardiac ICU. I think this is an interesting and important study to point out because in the surgical ICU, the average number of medication errors per month decreased. However, in the cardiac ICU, the total number of medication errors increased. This really should just drive home the point that the technology is not inherently helpful. It's got to be strategically implemented and used. To further bring that point home, there are certain risks that are introduced because of technology, such as workarounds. When staff is not sure how to use the technology or the technology is not working optimally, we're subject to a lot of workarounds. And this might be more dangerous than just not having the technology at all. Some examples of workarounds that I'm sure everyone's familiar with, workarounds to technology, include scanning one bottle when preparing a batch of IV room medications instead of scanning the bottle used in each preparation, or removing medications on override, which is removing them without pharmacist review. So I'd like to end this with saying that minimizing the use of workarounds is a constant challenge, and that the technology requires, as I've said many times throughout this lecture, strategic implementation and strategic use. So my final learning assessment question: which of the following types of medication errors are potentially prevented by the use of profiled automated dispensing cabinets? A, prescribing error. B, the use of an unauthorized drug. C, wrong administration technique. Or D, monitoring error. All right, and the answer to that one would be B, the use of an unauthorized drug, because the profiled cabinet would not allow the staff to retrieve a medication unless it's been authorized and verified by a pharmacist. All right, thank you very much.